Uh,
show the earlier the better, better the mortality. And the studies that are comparing the liberal quote to conservative fluids are much later in the course, hours into the ED course or in the ICU. So,
all right, finally got out of that one. Hey everybody, how are you doing so far? Hey Corey, how are you? If I haven't seen you for a while. So you should have been, hey Corey, you should have been with us at the meeting in Florida. It was great. We missed you. That's to me losing my memory, right? No, but thank you.
What? There was a meeting?
Yeah, no, but listen, seriously, thanks for stepping in, especially at the last minute to help us with the awards, because I didn't know where we were going with it either, but we did.
No, I really appreciated you telling me which award I was going to be talking about and changing it as you passed it to me. I liked it a lot.
And the best part was I was even looking up and going, now who's this going to? Who's next? Right? Because I had even forgotten what you and I had talked about 3 weeks earlier, right? So it was pretty funny. It really was. But we pulled it off. It went pretty well. The feedback I've been getting about the meeting has been terrific. It's because because especially when I think about me putting it together on Saturday, like Saturday and Sunday, for the most part, and you guys were also helpful. It was really great. Kevin, thank you so much, by the way, for helping at the make sure we were up to date on all the names and what's the word I'm looking for, titles, and put the all the cities in declining order of population and all that kind of stuff, right? And
anytime, Paul.
Yeah. Hey, and then were you surprised by finding out some of the cities where they were in the population, because you perceive that they're probably sorry, it was Rob Dunn. You probably perceive that sometimes that some cities were bigger than they were. It was kind of interesting when you go through that. Their metropolitan areas might be big, but the city themselves may not be that big, right? As you went through that.
I was actually, I was shocked actually. Yeah.
Shocked indeed. It was electrical. Wow. Okay. Interesting.
Hey, Julian has started the recording. He stepped off. He has to go meet with his medical director. He wanted me to let you know that.
Okay, good. What's the super Semper Gumpy? Who's that from? Chris? Okay, got it. Oh, he's flexible. So good. Thank you for being flexible, Chris. And it was great you were there, by the way. So I'm glad we got you there. It was really it was fun. So thanks so much. Okay, Semper Gumby indeed. Thank you so much for sharing that with us. So all right, let's see. We don't have a whole lot of people on the call yet so far, which is kind of interesting. But Erica, I want to definitely get to you because I was going to be pulling you in last week, and then you had to get off. What kind was it? A SWAT operation, or what were you called out? You had a call out to something last week.
Oh, the only protocol my crews have to call me at my biggest agencies are for field amputations, and so I got called out for potential field amputation, but it didn't end up. Thanks. Yeah.
Yeah, if you can, you like to avoid those if you can.
Exactly, yeah.
Corey, ever told the story about the guy who they did the amputation on? They found out it was the wrong leg, so they had to cut off. They had to cut off the other leg, that kind of thing, right? And then what was the punchline, Corey? The Corey was like, he tried to sue, but he didn't have a leg to stand on. Boom, right?
That's so bad. He's all right now. He lost the left side.
Yeah.
No, it's interesting though, because the politics in the fire industry where I work, they, for the very first time, actually utilized my request to deploy me if and when this was necessary. And the first time, I've been the medical director for this biggest agency about 5 years now. The
Yeah.
first time they needed me to deploy was actually during NAMSP.
Huh.
So I was on FaceTime with them. So I was talking to Ben Abo about it.
Yeah.
Ben Abo. And we were comparing the medical directors who have had to do that via FaceTime. There's about 4 or 5 case reports of it.
Wow.
It's a very interesting conversation. Yeah. So
Yeah.
twice now I've been called out, but
Okay, got it. Interesting. Well, so hey, just as an FYI to everybody, I've just well, anyways, it was great that that was kind of cool then that happened right at that point in time of all time. So that, has anybody here done a field day amputation? By the way, got called out for such a thing? Anybody here actually did it? And then the next
Only in USAR training, Paul.
Yeah, okay. And then how about, does anybody ever actually, does everybody have a protocol or a team that gets called out for it besides themselves? Because we did this before. I remember we had some kind of inquiry about this, right? So,
We go through UC Davis and they deploy the local trauma surgeon.
yeah,
And in addition to one of the urban search and rescue team physicians.
yeah, okay, got it. Hey, so hey, Kevin, when are you getting on your flight?
It looks like people are lining up, Paul. Sorry, I'll have to jump off early.
Okay, anything to pass on to us? Did well, first of all, did Eric Sarai have a good time? Did he enjoy it?
He had a fantastic time. We're going to be bringing more people next year, but the groundswell has been incredible. The emails are still coming in about people wanting to connect to talk about the active shooter training.
Okay, good. All right, fantastic. Then we'll tell him thanks for his contributions and for being there. We're sorry we're going to miss you here. But anything you need to report to us, either out of the registry or NAMSP, since you're on?
No, I'm headed to the NMSP board meeting, but I'm stopping through Las Vegas to give a Lifetime Achievement Award to Rocco Miranda's family. For those of you who don't remember Rocco Miranda, he passed away earlier this year, and his family will be at the AAA conference in Vegas. So I'm stopping through to award his family posthumously a Lifetime Achievement Award.
Nice. Okay, very good. Yeah, Rocco is great. So thank you. That sounds good that you're doing it. Where's the board meeting happening?
It's in Raleigh this year.
Okay, got it. So would it be hosted by the president of the organization then likely?
Absolutely.
Good.
None other than Jose himself.
Okay, we'll say hi to him if he gets on later on then. Okay, good. All righty, so then let's go ahead and move along on some of the topics. One of the things I did want to bring up, especially since you know, like Kevin's here, I got lots of emails here coming in from people pointing out that they were on vacation or whatever. For example, Dustin, who's always on every week, is climbing Mount Adams, I think, or no, he did that already. Mount Baker up in Washington, up near Bellingham, Washington. So he was like, go through the same thing with Fiona. She's out on vacation and several other people. So I got that. But that brings up a really interesting question, because next Tuesday is 4th of July. And so do you want me to sort of bag the meeting for, because I think most of us will, at the very least, would be with families or holidays, or in a lot of our cases, be out at some festival that's about to go down and we have to prepare for it. So I have a feeling next week might be the first time I'll cancel it. You know, anybody have any strong feelings about that? Does anybody think it's a good idea, by the way? No,
Yeah, I think it's a good idea.
Very reasonable.
Okay, good.
Yeah.
Because I know a lot of people actually tell me that they really kind of count on this meeting and they want to be here. So, but I think we
I
can,
think 4th of July we will have to just tough it out and miss the meeting.
yeah. Hey, you know, there was I was always so busy on 4th of July. I remember one car wreck I went to on the South Freeway in Houston, and I literally did 5 intubations. I went from like one car to the next. It was busy night, and that wasn't even a mass shooting. It was just a car wreck, and but they had multiple people in the different cars. So it was yeah. So I just know they can get really wicked busy on 4th of July. It actually starts in the evening because people have been drinking all day, of course. as opposed to later on with the fireworks when people start shooting in the air wherever they are, and realizing that bullets land somewhere, right? So, which is kind of an interesting. All right, well, all right, so then we'll meet each other then. The 4th would be the July 11th is when we'll get back together again then. Okay, I guess, does that sound correct? July 11th, yes. Yeah, because I have to be back in Dallas for my birthday on the 12th. So my birthday is the 13th, so they want me to come back. And I did spend the weekend with my new grandchild, Corey, so I'm trying to catch up with you, just so you know, all right? So, hey, let's see, let's go ahead, I'm trying to think, well, let's go ahead and start with, if you don't mind, with Erica, because we haven't had a good report from you for a while, Erica, and you couldn't make it to the meeting. So we want to catch up with you. Give us a sort of a year-to-date report from Kansas City and tell us what you've been up to and what struggles you're having and also what cool things you're up to.
Cool things. Well, our Chiefs, no, I'm just joking. Everybody knows how well the Chiefs do, but we did have the NFL draft. Dr. Dunn, the Detroit Fire Department, was able to join us with that. I feel like it went well. The other big part this summer is we've got a huge amount of celebrities coming through for concerts, which you're very used to, Dr. Pepe. I'm actually sure you'll probably be working one of these events potentially. So it's just planning for that. Our biggest issue right now, though, is opioid overdoses. Kansas City historically has always been an upper city that likes their uppers. They love PCP, cocaine, meth. For the first time since I came back from maternity leave about a year ago, the first time ever in my entire career, I've been doing pre-hospital emergency medicine in this area for 20 years. And for the first time ever, opioids actually overtook our uppers. So we are walking through the walk that a lot of you guys have already had to unfortunately walk through, and lots of young deaths with that. And then obviously a lot of trauma too. Summertime is our penetrating season. On top of that, just short staffing. So cool things that are going on. We've actually got positive movement on the EMS side. EMS education is actually going very well, which is a first for us. We've got good buy-in on the city side to support that. So I'm hopeful. My biggest agency is just waiting for a permanent fire chief. Once that gets named, then I feel like we'll be able to gain some more traction. But
so should I assume that then Donna Lake stepped down, or is she still there?
She did. She retired. She was offered another position that was too good to turn down. Yeah. And so the interim chief is selected because he does not want to be the fire chief. And my endorsement for an internal hire, I've already endorsed, but there's the discussion of an external candidate versus an internal hire. So we're walking through all the politics of that right now. But
okay, good. You mean you have politics in Kansas City?
Yeah.
Interesting. Wow. So or in Missouri and Kansas all together, right? So,
oh yeah, both sides. Yep.
I don't know if you could talk about it, but what's the latest from Wichita? What's happening out there?
I actually don't know that one. That one's a few hours too far away. I don't know if Dr. Goodlow has more input about.
Yeah, we'll see
that part of it.
And then more importantly, how's all your young champions doing? Okay, how old are they?
They're doing really good. Yeah. I think the best thing for me, and I will say, being the first female in my position, I was the first one to go on maternity leave and to pump and to do all of that stuff. And I've received support from around the nation. The amount of women who have been EMS physicians and or fire chiefs, it's a special group of people, great support. Now you can be a parent and be in these positions and do it all. And I feel like our men are starting to benefit from that as well. We've got better paternity leave now. A lot of good conversations about how to pump in the field and the stations. So I was able to use my experiences and learn from others, and then also hopefully benefit the younger generations coming through. So
okay,
overall,
great.
Very well. Yeah.
So you've always been a pioneer, vanguard. That's great. So it's good. Thank you so much then, Erica. So we've got to definitely get you down to whatever we do next or wherever. We'll keep you in mind because we just really missed you a lot. You're just part of Yeah.
Yeah,
So-
one of my partners, actually 3 of our partners retired in our ER shop. So we all had to pick up extra shifts for those 2 months. And there was just between meetings and stuff, there was nowhere else to put those shifts. So
Yeah.
unfortunately had to stay in town this year, but I appreciate the invitation and I really missed you guys.
Well, I got a lot of stuff going on, but I'll try to make it out to one of those concerts because
Yeah.
I feel like I got to go into Gates. Was it Gates Barbecue where they chew you out as soon as you
Yes.
walk in the door? They're always yelling at
Yes,
you, right?
they will yell at you. That's right. Part of the
Yes, I'm back.
experience.
I'm back. Please
Oh.
feel free to yell at me, right? That's good.
Yeah,
All right, good. Well, listen, thank you so much. It's great catching up with you. I think
Yeah,
everybody else
it's good to
appreciates
see you guys.
Hey, Rob, how'd you like, you know, you have to be in and out. How'd you like hanging with her?
Oh my God, it was great. I only hope that we can make our draft experience as good as theirs. They did a tremendous job. And R&D, right? I've got a ton of great ideas from what they did. And we had, like 15 people from the fire department, fire marshals, EMS, everybody down there to see what they did.
Yeah.
Why reinvent the wheel?
No, it's good. Fantastic. Well, that's part of why we have this connection here. So this is fantastic. So really good. All right. Now let's just, we do have a quick announcement I want to make. I guess we're getting pretty good. Got a little bit more of a group coming in. Keith, Lori, I understand that you had an article today in the New York Times and that Peter Antempy was going to go run down 30 minutes into town to go pick one up for his camp where he's working. But I said, don't worry, Keith will get one for us. So that's great. Can you get on and share with us, Keith? See, I think we should do a thing where we allow people. Are you there, Keith, by the way? Yeah, there you go. Pretty cool. So we made it to the New York Times here. Anyways, at least I should say some of us, right, on this, but it includes Joe Holly's in there, right, as well. So Keith, can you talk to us or what's up? Are you there? Maybe not. I can't hear his voice. But anyway, so this is the thing most of you probably have already seen before. But
let's try that again. You guys hear me?
Yeah. So
Right.
this is the thing that most of you probably have seen because we sent it out electronically before, but it actually came out in hard copy today, and it was really good. And we've already got some good responses on it, which has been really nice. And I love how the headline, not only said it improved, but it helps more patients survive cardiac arrest with full brain function, which is, well, that was actually good, Laurie. If you're here, I don't know if everybody heard that talk, but that's on the phone, but that's probably worth going over again because that was fantastic information that you're getting now with everybody being CPC 1s. I thought it was pretty cool. Keith, do you want to make a comment about this or say anything about this?
Only to say it was great to see everybody at the Eagles meeting and thank everybody for participating. We're still enrolling patients in the registry. Dr. Joanna Moore is in charge of it, and Paul is inking the revisions on the critical care manuscript we talked about. But from everything we can tell, if you put this combination of treatments on rapidly, we're continuing to see some really wonderful results. So.
But the thing that really is getting my attention now is that there's a lot of interest from the in-hospital groups. Everybody who works in everything from operating rooms to ICUs, cardiac cath labs, they're developing a clear interest in this. And I think we're going to get better data in there, meaning, a better chance of getting them back because you get it on faster. Because when we just showed the data that they quote in this article, where these were asystole patients, a lot of them have been down for probably an hour sometimes, right? Let alone, because they were unwitnessed cases that we responded to. But when you start tailoring it down to the cases in which we got it on board, half the time we got it on board within, I think like 10, 11, 12 minutes, something like that. They were just incredible outcomes. Even if we got it on within a quarter hour, it was like really pretty good, even in these non-shockable cases. And then Keith, you guys published stuff previously on shockable cases, right? Did that come out pretty good as well?
Yeah, if I might, take you back to my talk from last week for a second.
I got other things to get onto, but I'd be glad to do that. But I think it's
Let me just spend a minute because this story continues to be really fascinating for me as a scientist and for you guys as well. I showed you this little thing where we, in our animal lab, took a bunch of pigs, 22 pigs, put them into VF for 15 minutes. Half of them got what I'm calling BLS, automated HEP CPR, right away.
Yeah.
Half of them got 10 minutes of BLS with perfect chest compressions. And then as an ALS intervention, they got this automated head up CPR.
So
And
to
I
be,
showed you- I showed-
to be
yeah.
clear, go back to that last thing. You're talking about, you put them into VF and they're not getting any CPR during that period, nothing? For
15 minutes, they are just sitting there dead.
Wow.
It's quite extraordinary. So this is
Okay.
to sort of mimic what would happen in a rural setting.
Yeah,
So
okay.
after a total of 44 minutes of being in VF, they get some epinephrine. We wait a minute and then we try to shock them back. And then if they come back, we follow them for 24 hours and we assess their brain function. That's the protocol. Okay.
Yeah, and then
So it is right.
everybody gets the same thing except for 10 minutes and 15 minutes here and the 25. Okay, got it. That's the only
BLS versus ALS intervention.
Yes.
Okay, and this is the first time we've done this prospectively and then randomized. This intervention was randomized.
Okay.
So if you look at 24-hour survival in these pigs, and these are all VF pigs, right? The
Yeah.
pigs that got the BLS conventional CPR, what we've been doing for 50 years, and then add ALS with the automated HEP CPR, there was only one survivor, and it was completely brain dead. No neurologic reflexes, no pupillary reflexes. It was comatose. Whereas about, I guess it was 5 out of 11 pigs made it in the severe group that got basic life support with head up CPR. And then 24 hours later, they all had normal pupillary reflexes, and they all had either normal or reasonably normal cognitive function. But what's new, and you've
Yeah.
not seen this, Paul, is a very interesting question.
Before you go on, though, what I'm looking at in terms of cumulative survival, you're saying they're still alive, they're still going, and it looks like around 45%. So I don't know what was what was the end there. Let's see.
Yeah,
So,
5 out of 11 make it to 24 hours.
okay, got it. Okay, that's fine. After 15 minutes of VF and no intervention. Okay, go ahead.
And you could argue that some of the pigs had some other issues, but this is a good snapshot of the opportunity and
Yes.
similar to what we're seeing clinically.
Yeah.
Now, we then asked a very interesting question, which was, after 44 minutes of CPR, if you compare the group that got basic life support with a pair of hands effectively versus basic life support with those 3 devices, after 44 minutes, was there a difference in their responsiveness to the adrenaline that they all got? They all got the equivalent of 1 milligram of adrenaline.
Right.
And the results were striking. In one group with rapid automated head up CPR, the coronary perfusion pressures went from 20 to almost 50. Whereas in the other group,
I apologize. I'm trying to make sure I understand what
yeah, you haven't seen these before. I'm throwing something new at you for a change.
but I want to know what's blue and what's red. That's number
Okay,
one.
what is blue is before epinephrine and then after epinephrine.
Okay.
This group got basically BLS, automated head up CPR, and this group got only ALS automated CPR, delayed automated head up CPR.
Okay.
And this is coronary perfusion pressure in millimeters of mercury. So the responsiveness of these pigs at 44 minutes was quite different if you started with a BLS intervention that included head up CPR versus you added it late. It was really striking, and it contributes in this VF model to whether or not you get the pigs back and how they do 24 hours later.
Yeah.
It's kind of independent physiologic verification.
So,
Okay, so this-
Paul, I have a quick question.
Yeah.
So Keith, is this intent on showing the physiology that getting heads up on as soon as possible, rather than doing X number of minutes of standard BLS supine CPR, is better to just to get the head up ASAP? Is that the point?
Exactly, Peter. And now while we showed it with neurologically intact or improved survival at 24 hours, you could always be accused of biasing something, right? This is about as unbiased as it gets. The prep is more alive if you do head up sooner. It responds to adrenaline quite dramatically differently.
But let me ask you a question. Let me ask you a quick question. So in the real world, we wouldn't be waiting 40, the total 44 minutes to do the interventions, including electricity. So I'm just curious as to why you chose that instead of just doing the typical sequence that you would when you find someone down.
Right. So the reality is we're trying to mimic sort of a rural setting where you have a sheriff who shows up and could have these technologies in the back of his car or her car, but you wouldn't have ALS on scene for a while. And we wanted to ask the question, should they start with a pair of hands or should they start with a more sophisticated approach? And then when ALS arrives, what should you do? And in terms of the drug delivery, we know that if you give this drug at any point in time, that is epinephrine, you're going to see a rise. So I wanted to stress this model more than usual, Peter, to see whether we see the difference. Now, I can't tell you whether we should be giving epinephrine at 1 minute, 5 minutes, 20 minutes. All I know is that you get more bang for your epinephrine buck if you give it late or even early. And that's shown quite beautifully here.
What about not giving it at all? And you know, and why aren't you including in the BLS package like an AED, if you will? So like if you could do the pigs, get them in VF, do the heads up, but shock them and just skip the epi altogether. I'm just curious if that.
Right.
if
So
that's an
this
option.
leads to, you're like a perfect sort of lead in. So this is the sort of the new approach that we're taking, which is start high performance chest compressions right away when you get there, transition over to the head up approach, make sure you've got a good airway management, and then shock at minutes 2 and 4, whenever. Exactly when to give epinephrine, I think we do not know. All I know is that in many pigs, if they have a decent coronary perfusion pressure, which we can measure invasively, even up to an hour, we don't have to give any epinephrine to have them come back and do well. So it all depends on the circumstances. The longer the untreated VF time, 15 minutes is a very long time, the worse they do, especially if you don't use head-up CPR. But with the head-up CPR approach, they do strikingly well, and they have a remarkably better response to adrenaline. So the unknown question then is, if and when to give epinephrine, how much and how often?
And then
Pete,
let me,
could I ask a question?
before you go there, Corey, let me interrupt. Is that you remember the pigs don't have underlying coronary disease that caused this thing. Don't get the VF mixed up in this too much. This is a model of cardiac arrest at a prolonged period of time. And I think that's what I'm seeing here. I'm not trying to get this back to whether you should give epi or not for VFib cases, you know, that kind of thing. And that's kind of an entirely different question. Okay. But go ahead, Corey, if you follow what I'm saying.
So the beauty, as I understand it, of heads up CPR is to increase the cerebral perfusion and cerebral perfusion pressures by decreasing venous engorgement. Why does this head elevation affect coronary perfusion pressures and responsiveness to epinephrine or not?
So I think that there are several reasons for that, Corey, that we can provide, and several that are completely speculative. But we do know that, to your point, when you elevate the head in a patient with traumatic brain injury, or a patient or a pig that's getting this combination of active compression, decompression, and ITD to pump blood better uphill, and the elevation to drain the venous blood out of the brain, that you are dumping about enough blood into the heart to increase the cardiac preload by about 30% or more. So you're increasing cardiac preload by doing that. Okay. The other thing that may be happening is that you are increasing the responsiveness of the vessels to not just of adrenaline, but to neural stimulation across the board, because the brain has more viability. These patients are gasping more, which means there's some reflex activity between the brain and the phrenic nerve. A little down in my mind, although it's hard to prove, that the vascular tone is probably higher when you put the head up and you preserve some brain neural activity, baseline basal activity. So you have it probably both on the preload side and the afterload side, is what I would speculate in answer to your question.
Thanks. I didn't realize that the head had that much blood in the venous system to increase cardiac preload. Thank you.
Well, it does. And then, I mean, that's the whole thing. Plus, you're getting more blood flow back in a sense of more stuff coming out of your heart. That's the other way of looking at it.
It's not just the head, it's everything above, your heart, because in the humans, we have the hands up on the Lucas device. And in the pigs, the arms of the front feet of the pigs are strapped backwards. So they go from basically being flat and supine to somewhere between 25 and even higher for the feet, 35 centimeters of height. So that venous blood is drained out and it's clearly enhancing.
Keith, I'm just, as you're talking, realizing yes, there's head elevation, but there's thorax elevation too. And that's where a lot of that blood is coming from. I appreciate your answer very much.
And actually, on the before I go to you, Peter, on the arterial side, you're going kind of one way, with the exception that, once you're in the aorta, the back pressure, it goes in the coronary arteries there, right? But on the venous side, there's a lot more contributing to all this. It's not just the vena cava, you're also talking about going down the spinal flow area, all the spinal veins, et cetera. You've shown that pretty well, right, Keith? And then I'll go to you, Peter.
Yeah, we have. And just one more comment, Corey, and we're going to do these studies really rigorously, but we put what's called a pressure volume loop catheter, a conducting catheter, into the right ventricle. And when you go from flat to head up, you can see that volume expand quite strikingly. So we know from a patient who has heart failure that they want to sit up. And what does that sitting up do? We don't fully understand, even as a cardiologist, but we know the diaphragm moves downward. We know we have bigger lung volumes. We have better circulation of blood through the lungs. And so that also contributes to the answer to your question.
And Corey, the final thing on the physiological side, I should say, is that when I presented our studies on unwitnessed at SAEM, I presented our studies on unwitnessed cardiac arrest presenting with asystole, previously called futile, right? And I asked everybody in the audience first, says, before I start, I talk about conflicts of interest and blah, blah, disclosures. I said I was on, that I was a morning person and all that was my only disclosure. But what I did say was that, by the way, my first question is, why is everybody sitting up to watch this lecture? Shouldn't you be or standing up, or shouldn't you be lying down when you get better blood flow to your brain? And I left it at that as an initial question. And that's what's really fascinating about all this. We are built that way. Peter, you have a question?
Yeah. So I think that the one comment during Eagles that stood out to me, and I've gone to sleep at night thinking about this, is, and it was hard to understand a little bit because of his British accent, but it was Mark Wilson, the neurosurgeon.
Yeah.
And he made a comment that was like a throwaway comment, but he says that when you chop off someone's head, which I haven't done in a while.
Yeah, that was great.
he says that all the organs in the body shrivel up, the brain doesn't. And he says that blood does not leak out of the bottom of the skull.
Yeah.
You have to go and dig it, and you have to cut veins open and everything. So I start to think that, is it possible that the heads up and the suction is actually like vacuuming blood out of the brain, rather than us just I always thought it was just kind of leaking out, but according to Mark's comment, it doesn't leak out. It has to be pulled out. Is there anything there?
There is something there. First of all, I just sent everybody 2 dates when Kerry Batista and a couple other folks are coming to the Pig Lab in Minneapolis when we were doing some of these studies. And for those who haven't been here, many of you have, we're going to be doing more pig studies. So you're welcome. Just send me a note. So to your question, it's a very interesting question. And there was a wonderful postdoc I had in the lab, is just now applying for cardiology fellowship, Carolina Rojas from.
Oh, Rojas, yeah.
So, and she's from Peru. And she showed me this article years ago where basically this paravertebral venous plexus, which is this vein system that bathes the nerves along the spine from the base of the skull to the sacrum, it's really pretty flat. But when you go upright, it opens up. So you have two things going on. You literally are sucking more venous blood out of the brain from the thoracic vacuum. And that passageway, the paravertebral venous plexus, actually opens up when you're more in the head up position than the flat position. Now, we're obviously not standing up. We don't do that with our head up CPR, and it'd be very hard to pump blood uphill. But even in that sort of semi-Fowler position, all the physiology works to not only drain venous blood more and prevent it from backing up there. But literally, I think, suck it out with the ACD. Yeah.
That's
But I
fascinating.
haven't tried the decapitation study, Peter.
Yeah, no, because honestly, it would provide more, in my opinion, information showing that the need to create the vacuum, rather than what we do today, is we just keep throwing positive pressure in there and we try to push.
Yeah.
And if we're doing only those two things, blood is not being pulled out of the brain. And I'm just, it was bothering me to hear that blood doesn't just drain out of the brain, even when you cut off the head. I thought that was fascinating.
Even though we haven't done this decapitation study, we have Korean colleagues who did the crucifixion study, as I call it, and it's really important. So the crucifixions, they put the pigs in VF, and then they put them up at about 40 degrees. And then they kept them with their feet down on a whole body tilt and their head up for 30 minutes. And they compared Lucas ITD starting in this position to Lucas ITD flat. And none of the pigs with the head up survived, and 6 of 8 pigs in the flat position survived. So I don't know exactly how they powered their study, but I know that you don't want to just put the head up and then start Lucas ITD with your feet down. You've got to do this in a gradual way with the feet and the legs and the abdomen flat. And so we do learn from sort of all of these things. And I do appreciate Mark. By the way, I appreciate Mark for the other thing he's doing. He has developed this Good Sam app, which I would love to get across this country. It's better than the other cell phone apps we have for cardiac arrest and basically the public being notified. But he's a pretty amazing guy.
So
I'm
listen,
gonna have him on the webinar in a few months.
Keith, you may not be seeing what's happening in the chat, but we're thinking about doing a heads off study, okay? And then we're trying to think how you would randomize that, but whatever.
Well, you're the expert on randomized trials now, Paul. So.
Yeah, Paul, you have to be double blind. You have to be double blind. The researcher would have to be physically blind.
Like it's going to be completely blind.
Sounds like it's a bilateral hemianoptic study that would be needed here, right? So double blind. All right, enough of this stuff. This is great.
Actually, Paul, this is Stein. Do you mind if I ask Keith a
I
quick question?
was just going to pitch to you. In fact, I saw that. So go ahead.
Oh, okay, great. Keith, I'm sorry if I missed this because for a few seconds here and there, I had to turn my head. But I'm really interested in what you were talking about, how this relates to efficacy of epinephrine being given. And I heard people ask some questions, Peter, Corey, et cetera, about, what if no epi? What is your endpoint about what you refer to as your bang for the buck with epi? Is that ROSC? Is that cerebral perfusion for that certain amount of time? What is your endpoint there?
Well, so I'm going to telescope in and out of that question for just a sec. As a medical student and then a postdoc in clinical pharmacology, I studied the mechanism of epinephrine and alpha receptor downregulation. So I was really into that for a long time. And then I got into the physiology here. And several years ago, when we were trying to go from pigs to people, we decided we needed to develop a human cadaver model, which some of you participated in. And before the human cadaver model, we had a pig cadaver model. So we drained the pig of all of his blood, and 4 hours later, we looked to see if you did actin compression, decompression, ITD, and head up, what would happen to all of the parameters to sort of simulate what we might see in a human. And then the man that I worked with for 25 years, Scott McKnight, says, hey, let's do this. And he injects in 5 milligrams of epinephrine into this pig cadaver 4 hours after we killed it. And sure enough, we see the pressure go up. So that's pretty interesting. So as I was thinking about the question of when to give epinephrine and how to give epinephrine, the question of using epinephrine as a sort of provocative agent or a biomarker for viability is how we ended up looking at the data in the particular study that I just showed you. And 44 minutes in, these preparations were twice as responsive to epinephrine. That's pretty cool. So now the question is, when should and when do we give epinephrine? And I think we don't know. Carrie Batista is on the line. I can tell you that Carrie and I and others have been encouraging folks who use this approach if they have a decent end tidal CO2, to go easy on the epi, because epinephrine is going to cause ischemia, it's
Yeah.
going to cause arrhythmias. And we already know from all of the large studies that even if it's given late, it's associated with a worse neuro outcome. And yet, as a pharmacologist at one point in time, as a cardiologist, and as a guy like the rest of us who takes care of patients, sometimes epinephrine is clearly needed to get people back. And Paul studied high dose epinephrine 30 years ago and tells me to this day he still believes in it. So I think the verdict is out, Stein. But one of the things we have to think about is, how do we do CPR when we're assessing the efficacy of epinephrine? And if we do CPR with a pair of hands with a 20% circulation versus doing CPR with head up in the suction cup and the ITD with a 70 or 80% circulation, the effectiveness of epinephrine and the timing is going to be very different. So I think we need eventually to look at that. And we're trying a bit to tease that out from our registry data. So that's the best I can tell you at this moment. I would definitely encourage you, if you're going to do head up CPR, to use some epinephrine, probably 1 milligram max every 10 minutes would be my recommendation. And I think that's what we're doing in St. Johns County, right, Kerry? Something like that?
Yeah, we do one upfront, mainly because it's associated with better ROSC, and then space out the time. And the problem with epi is everybody thinks something different than AHA needs to be done, but nobody really has any great idea what that should be.
Well, here's the deal. I want to make sure it's clear. When you're saying that, is it for VFib cases or non-VFib cases? Okay. Because
Non-VFib cases, we're doing every 5.
Yeah.
So
right. That's what I'm
so
getting at.
non-VFib is different because the physiology is different.
So Stein, what I was getting at before, as I pointed out, there's all these complications when you're using epi with the ventricular fibrillation in a human, so to speak, because they have all these underlying issues in the first place. Okay. And then the longer you go out, you can maybe get them resuscitated, but then, it's probably too far out, at that point in time. So I for example, when we used it in children early on, there was much better outcomes. All right. And so it's a different model, so to speak, under those circumstances. And so, and sometimes we may not be actually using enough, but the sooner the better. It's like one of those things where you go out too far, then you're going to get someone resuscitated, maybe, because it will do it, but they may have gone too far. And what we're doing here by getting normalized blood flow to the head during CPR, it's not you're still doing CPR, but you're augmenting it. You may not ever even need epi in the long run, is what it kind of comes down to, I think. But
In the heads up, you're staving off the vasoplegia that comes on.
Yep, because you're getting blood flow back again, so that's what's good. That's what's great, that you're parameter. So anyways, it all may sound confusing, but it just has to do what's the model, what's the timing, all those various, there's so many parameters here. And Keith was wise to sort of point that out, as we were just hearing before. So let's just do, I think you do this first, get better flow back, and then we move on from there, that kind of. Right.
Why are we not, just out of curiosity, why are we not using an endpoint about if epi is effective or not based on CPC scores, at discharge as an endpoint, instead of just do we regain ROSC? Those are questions that I have. I'm particularly interested in it just because I think I've explained to some people that in our system, we do not regularly or systematically use epi. We do use it, but we do not systematically use it. And we found that our outcomes based on CPC scores of people leaving the hospital neurologically intact have been much better than before when we were routinely using it. And so that's why I ask these questions. I would absolutely love to participate in Keith's study. I just can't get the finances from my department.
There's a line. There's a line there, right? Like you could get, you want to give some epi because you want to, it is associated with some ROSC, but you don't want to give too much to where you're causing harm. And CPC scores is what's important, but if you can get ROSC on 1 or 2 of them and get 1 or 2 more back, that's adding to your CPC score. So there's a way to thread that needle.
Yeah.
That
Also, Paul, can
Yeah,
Paul,
just,
can I
yes, I'll let you in a second, Terry. Just, I want to just move things along though. But I just, I think when I'm listening to all this here, Stein, I don't think there's any disagreement with what you're doing and what you're seeing and what you're saying, because it all has to do with timing and all those various issues here. They're all saying the same thing here. So first, let's go to Terry, then to Ben.
The answer to that question is getting more people back with ROSC doesn't mean you're getting more people back whose heads work. And
Right.
that's the outcome I would submit really matters to people.
Yeah.
And the other thing, we do it because ROSC is the only thing that you can see a difference in with a small enough sample set that we can afford to do it or have access to do it. The other ones require huge sample sets to show a difference. I'm
Right.
done.
No, that's fine. And I think no one's having any disagreement with this, but I will say that with the head up thing, which is a good place to start with, it's like, is that Jeff Goodlaw? I don't know if you're able to present those slides real quick, Jeff, or not. I don't know if everybody saw that.
Let me, I can pull them up, Paul.
Yeah, but look, I think everybody's actually ironically in agreement here. It just has to do with the broader picture of what we're talking about here. All Keith was showing you, I think, is that when you should start this thing, or if you're way down for a long time, you should start this thing right away and not do basic CPR for a while. This should be part of this should be basic CPR from now on for what do you call it, workers. That's my impression that I'm getting from that. It was just a physiological experiment as opposed to an outcome experiment per se. So, and but it has its I think it's showing us that you can achieve better blood flows when you have these long prolonged response times and so on, and that other things are more responsive. But yes, everybody's in agreement. We should be looking at CPC ones, and that's why I think this has been very interesting. If you take a look at this, so go ahead, Jeff. As everybody knows, Jeff Goodlow, right, from Oklahoma City and Tulsa, and he started doing this a little while ago. And Jeff, this is just very, very preliminary, but I think it's enough for me to want to start, at least dropping this on people when so it should be part of our endpoints from now on. And we're talking about CPC 1s versus 2s here, Stein. Okay, so go ahead, Jeff.
Yeah, so the quick takeaway, everybody that survives in Edmond, Oklahoma, where everyone is above average and all the children are beautiful, everyone that survives is a CPC 1 now. 100% of survivors for calendar year 2022, which was 9, and 100% of survivors until June 1st, which is the last data cut that we had, the 6 out of 6. And that is not all VF. We have a few in there that are non-shockable rhythms. Overall, you can see the survival, particularly in the last 2.5 years, overall survival has gone from 5 to 10 to 20. And look at that top graph there on the shockable rhythms, and it looks like it's off the chart. It's practically off the chart because again, it's 100%. Everyone that we have found in VF this year has survived, and again, neurologically intact. So good things are happening. The baseline CPR quality very, very high in Edmond, which is why we rolled the Eligard device out there as opposed to other aspects of our system. But not that Edmond is that far above the mean, but there is a little bit of difference there. And so based on this data, again, particularly the CPC outcomes, we are really promoting expansion of Eligard throughout metropolitan Oklahoma City and Tulsa now.
So I want to make sure I know what I'm looking at here on this chart. I guess down below it says the CPC 1 is a certain color. So when you see these, so I assume that thing that's a real tall one that says 9 is 100%. And then before, are those ones as well that were at 70% and 88% and 76% walking back? Is that correct?
Yeah. Yes.
So the point is, okay. Yeah.
Historically very few 3s and 4s, but keep in mind, like almost any community, we do have extended care facilities, skilled nursing facilities. So a few of these folks that you see and might have concerns about CPC of 3 they very well may have started as a 2 or 3 in a nursing home. And as proud as I am of the guys and gals in Edmond and really all of our system, we have yet to find a way to take somebody that starts as a CPC 2 or 3, has a cardiac arrest, and then turn them into a 1. We're not that good.
Yeah, but I guess the bottom line is that most of your patients were 1s, still most, and you're just doing a good job there. And that's kind of what I've always experienced. But we've always had those 2s in there, which are about, could be a third of them or something like that. So the trend you have right now is, again, we'll have to declare it's a trend, but it's impressive. And, and so keep up the good work then. That's all I can say. But the point is that to answer your question, Stein and Terry's, is that that's exactly what we're focusing on now, no matter what we're doing at this point in time. Okay, so whatever it's worth. All right, I should go on to some other topics here. We'll try to get to Eileen as soon as possible. But anybody ever have any other questions or anything else to add? I didn't mean to go that direction, but I'm glad we did. It's kind of an interesting point, though. Okay.
You don't want to talk about epi dosing variations more?
Yeah, let's do that next week. We can do it.
Yeah.
You guys come back and do it on the 4th when we're not.
Yeah.
No, but I mean, I'm all been in favor of using the, not just getting a dose, but, giving a drip of some sort if we're going to do it. And there's reasons for that. So, okay, so that's basically it. So let's go on. I wanted to really get to this thing because I wish I have a tape recording of Eileen did a great job last night on CBS, a local affiliate here. But they were talking about, like I said here, the malaria scaria and their little carriers, right? And so you can just want to give us some perspective that we should be concerned or just have a heightened sensitivity to it or anything like that, Eileen, at this point in time, because there have been, 4 malaria cases and they're not totally random like we've seen in the past. This seems like something's happening over there on the west coast of Florida. I want to go ahead and fill us in.
May I share my screen and show you a little quick slideshow?
You may share your screen at any time.
Alrighty,
You did a great job. I stayed up to watch you on TV last night. You were great.
Oh, you are so sweet. You are so sweet. Okay, can you see my slides?
Yeah, it says malaria in Florida 2023 and Texas. Okay.
That's right. So
now, is
this
there a correlation with the kind of governor you have?
No comment, staying out of the politics altogether here.
Okay.
So what you're looking at here is a SkyZont of Vivax malaria. So I'm sort of giving away a punchline as to what's going on. Here you see a reticulocyte. So of the 5 species of malaria, 2 of them particularly love immature red cells. So that's why and immature red cells are bigger than the mature red cells. So when you're looking at a case of Vivax orovale, you're going to see it in bigger cells because they're more immature cells. Okay. Yeah. You can actually see a few more trophozoites here and here on this slide, but so actually, what's going on is not imported malaria. It's malaria that has been acquired in the United States, and that's why we are concerned. So as you can see from what's written there, it affects upwards of 219 million people a year. And in the US, we generally see imported cases, about 2,000 imported cases. That's somebody who got their malaria somewhere else and came to hospital or care here. But it is a killer. It kills 660,000 people a year, mostly little children, mostly in sub-Saharan Africa. And I already gave away the punchline that there are 5 species of malaria, which you can acquire in different parts of the world. And the truth is that about 2.2 billion people are at risk for infection by the worst one, which is falciparum. So when I was first learning tropical medicine, we used to say, Plasmodium falciparum kills you. The other ones make you wish you were dead, just to give you a picture of what it's like. And so, yes, this was on the news. And the most important thing is this bit that we now know that it's Vivax. So let me just give you a little bit, just a tad of history, because that makes life fun. I think it's fun. That this sort of obscure guy working in Algeria is the first one that saw malarial parasites. He was working there in the late 1800s. But he didn't distinguish between all those 5 types that we now know infect humans. And there are many other types of malaria. There's bird malarias I've worked on in Africa. It's a really interesting disease. But for humans, 5 species. And it was these 2 Italian gentlemen that first identified Vivax as a separate species. But it wasn't until 1982 that we learned one of the most important things about Vivax, and it's really critical to this outbreak. And that's recognizing that there's a life form in the life cycle of malaria that sleeps in your liver. And since they sleep, they were given that name hypnozoites. And these were found in 85 to be the cause of relapses. People from parts of Africa that don't have a Duffy blood group don't get Vivax malaria, but they can get any of the other kinds of malaria. And we still can't culture it in vivo. There is no vaccine for P. vivax like there is for falciparum, and we can talk about that later. But the odds of dying from Vivax are about 2/3 of that of dying from falcip, but it's still real. It still can happen. And the cases that we've had have come to care. So we don't know if there are some subclinical cases out there, which you certainly can have. So to show you the big thing about the Vivax, which makes it so different from falciparum and from malariae and from Naloxone, but not from Ovale, is this business that once the sporozoites, which is the product, the baby made by the sexual stage, which happens in the mosquito, gets spit in the saliva under your skin, it's going to go to your liver, and it can either become a hypnozoite or it can mature into schizonts that rupture and release merozoites. Now, the transmitter is a mosquito of the Anopheles genus. And we have had outbreaks like this in Florida before, where we had a little endemic focus. When I was living in Maryland, we had an endemic focus there for a little while in little islands on the Potomac River. So it happens sporadically in the United States. But it's important for everybody to know that malaria used to be a huge problem in the United States. And primarily it was Vivax and falciparum, the big killer, throughout the United States, all the way through to Maine, Wisconsin, what have you, and even into Canada. So we wiped out malaria from the United States. It's one of the reasons that the CDC was founded, was to wipe out malaria. Of course, we used DDT, which was bad for the environment. But anyway, it can come back. And something with hypnozoites, and I've treated patients in MedReady's in Latin America recently with FIU, an Operation Continuing Promise, where I saw that they were still using just chloroquine to treat people with Vivax malaria and not giving them the 8 aminoquinolones that you need to eradicate the hypnozoites. So if somebody like that who's been partially treated, feels fine, and is carrying the hypnozoites in their liver, comes to the United States, that person can have a relapse, and that relapse can lead to enough parasites in their blood that our Anopheles mosquitoes can then get infected and allow for further infections in the United States. So the most recent one in Florida was 8 cases acquired locally in Palm Beach. There have been imported cases, of course, and the largest import was in 2012 where there were 65 cases imported just to Florida. This is how we can tell that it's an Anopheles larva. It's sort of very particular stuff. This is a particular species of Anopheles taking its little blood meal. They have a tendency to feed in this funny orientation, so you can tell them apart. These are the 8 Anopheles species that are actually capable of transmitting malaria that are in Florida. By far the biggest transmitter in Florida is this little guy here, this unpronounceable name of Quadra maculatus, and it's called that because it's got 4 little dots on the back. I know you probably don't want to know all that, but it's kind of fun. These are the mosquitoes that we have in Florida. There's actually 13 different Anopheles species in Texas, and they also have this one, which is it's just really good at transmitting malaria. Clinically, of course, you get those fevers. Vivax malaria is a tertian malaria. Falciparum is a tertian malaria, but that's a malignant tertian because historically falciparum is the one that kills you. But again, people with underlying diseases, either concomitant acute illness or a chronic disease or pregnant, or I should have put young children as well. Those are at higher risk of having severe disease, and severe Vivax can kill you. The most common way in which Vivax kills you is splenic rupture. So this is considered a medical emergency. And you obviously have to be very careful about, where you touch somebody who has an acute malaria from Vivax. And so there you go. So standard shaking, chills, headache, muscle aches, tiredness, sort of flu-like symptoms, but nausea, vomiting, diarrhea can happen. It can cause anemia and jaundice in some individuals, and it can, as I said, be deadly. Blood smear around the world remains the main way of making the diagnosis. I'm showing you thin smears because they're much easier to diagnose. I'm showing the Schüffner's dots, which are these little caveoli that pick up the dye that you see classically in Vivax malaria. By the way, the name Vivax is because they have these sort of amoeboid shaped trophozoids, so they seem very vivacious. That's where the name comes from. Because they like to be in reticulocytes and there are fewer reticulocytes than mature cells in your blood, it can sometimes, on a thin smear, be hard to see. That's why in malarial areas we'll do a thick smear, but those are awful to look at. So I decided not to even bother showing you. There are rapid tests. The Binax Now is the one that the CDC recommends. That particular one is not as sensitive as microscopy. There are better rapid diagnostic tests than the one that CDC is recommending, but they're not yet popular. PCR is much more sensitive. We can detect it much more sensitively than routine microscopy, but if you don't have the wherewithal to do PCR and you have to send it out, it's going to take more time than doing old-fashioned microscopy. But it's very useful for confirming the species, especially those who aren't practiced at looking at these slides. And of course, it can detect extremely low density, and it is it's a way of realizing that there's a lot more asymptomatic P. vivax than we thought. So this is just a standard way in which we do the multiplex, and it allows us to actually speciate using PCR very quickly. How do we treat it? I couldn't not show you this old commercial by the United States that said avoid malaria, use chloroquine. And when I used to work in Africa in the 80s, we would have Malarial Monday. That was reflecting the fact that once a week we would take a chloroquine pill as prophylaxis. Now I use this Malarone, which is atovaquone proguanil, which is phenomenal, has almost no side effects that I ever feel, although of course some people can get side effects from any drug, but it's a very safe drug, incredibly effective, and still effective against all kinds of plasmodiums, so including, of course, evil falcip. I will tell you quickly a very sad story that when I was working the Ebola outbreak in West Africa, my friend Peter Fury came and took my place where I was. I had been taking Malarone because falcip is very big there in where we were in Potako. And he did not take the Malarone, and I lost Peter. He died. Yeah, he died. He was.
I do have one question. Is this woman here shown in the photo? Does she have any DEET on, anything like that? That's
clearly not. She clearly forgot to put on a mosquito repellent, and I think everybody here knows about the main environmentally approved, ETA approved repellents, which of course are picaridin, that's my favorite, or icaridin, IR3535, which is also phenomenal. In fact, Avon sells one that has the IR3535 and sunscreen, so that's usually my go-to here in South Florida. DEET, of course. DEET works very well. It was developed by the US Army, actually. And then there are two products that are made from eucalyptus. Best known is oil of lemon eucalyptus, and the other one has a name I can't pronounce. And then there's one more that the EPA just approved, which is made from strawberries. And I'm not, it's another Urtic name that I'm not familiar with, but it's easy to look up. So, but there's plenty of options as to what to choose. There is no vaccine against Vivax, as I said before, and none is actually on the horizon. And the PFAL-CIP vaccine that is WHO approved only has 29.9 to 33% efficacy. So not great, but great for little children in highly endemic areas of PFAL-CIP. Not something we need. We don't need to be using this Malarone. We need to be doing mosquito avoidance, wearing light colors, long sleeves, long pants, etc. if we're going to be out there, but loose fitting so that we're not terribly hot. Of course, how do you treat the hypnozoites? I mentioned before, 8-aminoquinolone are what we use. The Primaquine is the one that we've had for many years. More recently, tafenoquine is a little safer, a little better to use, especially for people who have G6PD deficiency. That's a bit of a problem because obviously people with G6PD can have very bad reactions to these 8-aminoquinolones, but if it's done judiciously, it's the best thing to do because you need to wipe out the hypnozoites. And the treatment, chloroquine is still used a lot in Latin America to treat, and they often forget the 8-aminoquinolones, but there are places you cannot use it in Eastern Asia, like Indonesia and Papua New Guinea. I like the artemisinin combination therapies to treat malaria. And that's all I had for you on that. And I hope that was useful.
So let me ask you this. I mean, is there any, this sounds like far-fetched, but still an interesting question. Is there anything to do with blood types? Does it matter? They just like blood, period?
They like blood, period. You know, the blood is used by the female mosquito to help their eggs mature. Right? So they need that blood being. That's why the males don't bite and the males don't transmit to humans. But in terms of attraction, there is some data that does suggest that certain blood groups attract certain species of mosquitoes more than others. And off the top of my head, I can't remember which ones they are, but there is that. But that's not. But they don't, once they take a bite, they don't really care.
It doesn't matter. The other thing I was going to say was that, but my joke about the woman they show to get your attraction, I'm sure, was that she, you know, the best protection is what you were saying, is wearing those, you know, long sleeves and protecting yourself from getting bit, or something that they can bite through, you know, at least. So that's actually a great point. So it is interesting. So now the next question is, let's go back to why want John in the first place, which is that, do you think this is a concern, or is it just some weird, you know, event, or should we just keep an eye on it and see what happens next? But you think this is the real deal because it's Vivax and it screws up livers pretty badly, right?
Well, you have those hypnozoites in the liver, and that's probably how it became endemic here. Somebody got Vivax somewhere else, got partially, you know, got treated for the blood stage and didn't get treated for the hypnozoites, then had a relapse, right? And then got bitten by our mosquitoes. And so now we have a colony of mosquitoes that have this. Can we get rid of it? Yes, we can, but everybody needs to know about it. And there may be more cases coming. It really depends. You know, there's actually something called airport malaria. Because mosquitoes will get on airplanes. And I don't know about you guys, but I've been on airplanes with unticketed flying passengers going around me. So yeah, those uninvited guests can actually travel and.
Yeah. Well, I always talk about how West Nile probably came on a 747 out of Tel Aviv, you know, that kind of thing in the first place, probably, right? So. Yep. Interesting. Hey, so the hypnozoites, didn't I read about them in the Old Testament? You know, the Hebrews had to come across, sorry, it does sound like one of those old timey, you know, like groups of people, whatever, or tribes. All right. Well, listen, thanks. That's really great. Anybody have any questions for her about this, though? For Eileen, that was kind of a cool catch up because there's a lot of stuff I didn't know about, quite frankly. And it's great to see what's going on. And I had to be, you know, when I'm on tour with some of these groups and we're going to various countries where they're really endemic, they really turn to me to say, should we get some Malarone or whatever, or should we get, you know, whatever it may be. And I kind of had to learn about what's endemic, what is there. And it's kind of confusing. And this was helpful to go through the different types that we had here today. So which was really good. So thanks a lot. By the
You're
way,
welcome, but I have to say, it's hard to follow Corey and the heads up CPR stuff. That's just so interesting, and the whole theories behind it and how it's working. I'm just awed by that.
Yeah, that's right. So Corey, are you got some malaria? Do you have malaria cases up there in
No,
Idaho?
but I have had some fevers I've worried about, but I think heads up CPR is a bit passé, and I think, as Peter was saying, heads off CPR may be the latest.
The latest fad is head off. Okay, good. He's not even hearing he's on the phone over there. It's kind of funny. So, all right, but Eileen, that was really great. I really do appreciate it. I got to tell you one thing though. I got the advice one time that as long as we were like when we went to India, as long as we were in the city, we would probably do okay because the water quality was so bad that the mosquitoes didn't live there. Once you got out though, the countryside of India, you were at more risk at that point in time. So that's kind of interesting. Well, good stuff. Hey, Stein, I was going to ask you to speak on some subjects because you couldn't present them in Fort Lauderdale, right? And but will you be available in 2 weeks, you think, to talk about some of the things that you wanted to talk to us about at that time?
Yeah, 100%. That would be fine. I'll check with you offline about exactly what.
Yeah, well, we could talk about it later, but one of the things was, your own experience with the tier system today, because we got really good feedback on it from Jeff Goodlow, who's on with us now, and Jeff Jarvis, and all the Jeffs were doing really good, and so on, and some of the things that they were doing in Raleigh and so on, and so that was kind of it was very, very interesting, from a lot of points of view. So it'd be kind of cool to see what you're experiencing so far. That'd be good. There was a lot of stuff do you remember what some of the other talks were that you wanted to do? Because I'm thinking what I want to do is I want to get couple of these little talks on every once in a while, like we just heard from today, that we get from Amal or from Amal or we get from, from Eileen here, like we saw today, right? I think one of the things that did you want to talk, was it you that wanted to talk about statewide blood programs or all that? Was that you?
Yeah, that was me. I was just putting in to potentially talk about how Colorado is trying to tackle the whole blood from the state down and do it as a statewide, not sponsored by the state, but all the EMS physicians and trauma departments getting together as an entire state and coming out with, the formulas that are going to work and the protocols and how to most efficiently use blood, right, and filling, and all that, and how to decrease waste in the sinks for blood and doing it as a statewide.
Yeah.
And so, I can talk about that for sure.
I think it'd be good. In fact, what we need to do is, if I can get Peter's attention sometime, because he's on the phone right now, is that we're having a blood coalition talk on July 12th. And if I can get him to put you on the program, we're going to have a couple presentations, but it might be worthwhile having you on and talk about what you're doing statewide in Colorado. That would be good. That would be excellent for our coalition talk. Okay.
So, I caught the last part of that. I already have Scott Branny. He's already invited on the list, and I've already emailed him, so we're good to go. So Stein, please join us. We'd love to have you on.
Yeah, and make some commentary on it, Scott, and you can give us, as an end user out there that's implementing this, it would be great to hear your perspectives on it as well. Okay, so that's good. Okay, good. Just want to make sure that's made.
Yep.
The other thing that I'd like to present maybe in a couple of weeks or something like that. If you're going to do one thing at a time, maybe we'll do the statewide blood at another time. But another thing is, I want to hear about what your church system is doing. But the other thing is that the reunification program for MCIs would be a nice little topic to hear from you. Okay, so if you'd be willing to do, we'd really like to do it. We're just sorry you had so many talks that I thought were very interesting that we didn't get to give. And I think it'd be kind of fun to insert those into some of the things we're doing here. So does that sound good?
Yep. Be happy to do it. Yeah, I was bummed I couldn't do
get those prepared, and obviously a 5 or 10 minute thing that would be really good for you to do.
Yep.
All right.
Yep.
Good. So I want to make sure everybody remembers that today our CME code for today. I'm trying to see if there's any other calls or nope, nothing else. Let's see who the participants are. And then, so what I want to remind everybody then is that I'm trying to, I lost it here. I don't know what happened. That participant. thingy here. But I do want to remind everybody the CME code for today is 17384, 17384. Okay. And then, so, hey, and Ben Weston, are you preparing another topic that you could deliver for us as well?
Yeah.
On that? Yeah. Okay. Yeah. Ben Weston. We just did the one about, the first one was about hospice and palliative care. A call for that for us in EMS. The next one you did was this whole issue about postpartum problems that people have and that we need to pay attention to. What's your next one that you're working on? And then we may have you present it to us first for some feedback, right?
It's under wraps because I haven't discovered it yet, but
Okay, good.
it will be discovered soon.
It'll be really special, that kind of thing.
That's right.
I
It's gonna
thought
be
you
great.
and David and everybody else there did a fantastic job on that. That was really cool. And with Fiona, et cetera, that was that was one of the better sessions. I really liked it a lot. So thank you so much. Okay. So
Thank you.
that's great. All right, good. Anything, well, I got John, anything to report out of Milwaukee?
I think we have the worst, or close to the worst air quality right now, in the world. So we're kind of dealing with that and shutting down a lot of activities.
What's the AQI looking like right now? Are you in the hundreds or?
Oh no, we're 200 and,
Oh my God.
yeah. What was the
Right.
last? I think right next door to us is 290, but the one closest to us is, I have it somewhere here. I think it's 211.
Okay, so is this all from the wildfires or what's the story there? Because that's unusual. Huh?
Yeah, it's all from the wildfires. It's concentrated right over kind of like southeastern Wisconsin. So like the Milwaukee, Chicago area.
Yeah.
Right
I
now.
really got interested in air quality because one time I'm walking around my hotel room in Sydney, Australia, and you can smell from the wildfires that were going off in the Blue Mountains, in Australia. And that was important for me because I had to decide whether the singer, let alone the audience, would be at risk, but the singer could go on because they're running around the stage, sucking more air in and singing, and so they're
Right.
breathing it out more and they're running and they're exercising. And that really causes a real problem, for them. They're especially sensitive, especially if they have any underlying problem. So I started learning more and more about it because then I broke it down now to the particulate matter as well that you get. And I think that's interesting. And some of this stuff, as much as this is, the forest fires are natural, the stuff that they're giving off ain't so natural, not good for us, right? So, wow. So then as the health advisor, what are you advising people to do? The usual stuff like stay home or whatever?
Yeah, it's basically, stay at home, close your windows and doors, put on air filters, back to talking about N95s for certain higher risk populations outside, checking on your neighbors, things like that.
Any effect on the ozone, by the way? Is there some correlation or does it affect it or just independent?
It seems to, well, this is getting into areas that I'm, becoming quickly as much of an expert as I can today, but I think it's mostly the PM 2.5. So the 2.5 microns or less.
Yes.
Is what the issue is. I don't think, please somebody correct me because I'm still learning here, but I don't think ozone has been as much of an issue.
I just didn't know if it affects the ozone itself, and that it has some interaction. So that's what I'm saying there. Just from a pulmonary doctor point of view, I try to know if the one thing affects the other. So like, how we know heat affects the ozone, is there also an effect from this as well, which compounds the whole insults to people's lungs. That's why I was asking. So if you knew that, I'm just doing a head speculation thing. So
I know our PM 2.5 is really high. Our ozone is not high right now, but
yeah, okay.
Arlene looks maybe like she knows more about this.
Yeah.
Certainly more than I do.
Well, yeah, you need to be looking into it. So this is, I totally forgot. That's high levels. So you're talking about almost India levels. Right?
We're beyond, so I've been looking into it. So it looks like Lahore, Pakistan is usually the worst air pollution in the world.
Yeah.
They linger at like 160. And
Wow.
so we're way above that.
Yeah, okay. And then Ryan, you guys are in Flint at 219, so you're up there. God, that's significant. Anything over 100 is pretty significant. So that's amazing. So, okay, good. And then Rob, are you guys doing anything particular with our EMS folks out on the streets or the is Rob Dunn still here by any chance, Ryan? Maybe he's not here anymore. Hey, yeah. Hey, Ryan. So are you guys doing anything for the paramedics or are you wearing N95s or anything like that out there on the streets?
No, we probably should. That has not been in the discussion yet.
Yeah, okay, we'll take that home to them because they probably should be thinking about it because it could be very serious for them. Okay, such a particulate material that's out there is really terrible, right? And then, so Rob, you're saying Harrisburg, Pennsylvania, was that hit 390? That's like unheard of, like bizarre.
Yeah, on June 8th, we were at, I think, 299, and Harrisonburg was 100 points ahead of us, and it was awful here. I just dashed across the street with an N95, and I knew, and I doubled my asthma inhalers that day, and the next day when I did my peak flow, it was obvious. And I just thought all those people that were marginal with their emphysema must have had a horrible time.
Yeah, exactly right. So that's really fascinating. I don't know what else to do, but it goes along right along with the talk we heard from Eileen, et cetera. And I'm wondering if we're going to expect to see more and more of this. So, all right, let's dash around we don't have much time left. Let me dash around the corners here and see if anybody else has anything. Bill, anything to add from I don't know if you're in Sacramento or you're in North Lake Tahoe today, but anything to add from that your part of the world?
No, we actually have good weather in California and Nevada at this time. We had high AQIs 300-400, 2-3 years ago.
Right.
We're trying to, in fact, do forest preservation and thinning to try to reduce those hazards, but we're certainly at risk for it in California and Nevada for it. For that, we did. I did want to give a shout out to Keith, who when we attended his pigs story, and the only thing I would add to that is, the model so far, and Keith is up to his ears in trying to do all these trials, is VF, which is induced VF by AC current. Most of our patients that come in with out of hospital arrest have coronary occlusions. So at some point, I think it would be reasonable, when you get time, Keith, to extend the model to say, if we tie off a coronary, does Heads Up make the same difference in that patient population for that? Specifically those who have a right coronary occlusion, where they don't get the normal RV pressure, because in that situation, we need higher filling pressures in the RV to try to push fluid across the lungs to get it into the LV, which to get our cardiac output for it. So I know you've got a lot of things to do, but at some point, seeing if the Heads Up model works in a variety of types of out of hospital arrest would be intriguing.
And we may actually ask our friends in ICUs and coronary care units to actually help us with that in the future, because you may be instrumented there and you may have ability to do that. But I guess we'll look at it from the model point of view. It's a little hard to get volunteers with right coronary disease or whatever it may be at the time. But that's a great point. All right, can I move along to David Miramontes, because you guys are having problems with something called heat, correct? David, are you there? David Miramontes?
All right, so can you hear me now?
Yes, sir.
All right, so today is the 1-year anniversary of our big tractor trailer MCI, where we lost 53 people in a refrigerated tractor trailer that wasn't refrigerated and then became a heat sink thermos bottle. So today is the anniversary. I've got a couple of guys that are on sick leave today because they can't be at work today because they're still flipping out about the body count that they encountered. But I wanted to bring up something good that came out of that. So we all know in Ironman and a lot of these other horrible marathons, when we get people with heat exhaustion or heat stroke, we throw them in the big bucket of ice, right?
Yeah.
And they do great. Some of them, they get discharged, they go have a beer and they're fine, right? But we've not been able to do that in the EMS world. So one of my colleagues, Brian Everett, is a really smart EMS physician, came up with using a body bag as a way of creating your own ice pit. So we don't call them body bags, we call them temp bags, temperature emergency management bags, right? And so what we do is we take a body bag, unzip them, put their head in the open end, and then we take 2 of the jugs of water that are on every fire truck and dump them on the patient inside the body bag. And then what you can do is then put them in the ambulance and they don't have this pool of water dripping out the back of it. And then when you get to the ER, you can bring them in still in this bag. So you're putting a couple inches of this ice water in on the bottom side of them. So you can still defibrillate using the pads anteriorly. You can still manage your airway. You can still do all the stuff. And it just seemed to be a kind of an innovative way of getting ice immersion done in the MS environment. If you don't have that, we're actually telling our engine companies to throw them on the stretcher, find a hydrant, and just wash the crap out of them. So we don't use tank water because our tank water has surfactants in it. So you got to use hydrant water for that, or any water, right? Get them naked, get them wet, get them cold. And then if you want to use the temp bag system. So I put our draft protocol in there. It's going through committees at STRAC. We've done it a couple times. It's been actually pretty effective. And it's not just all runners and people that work outside. I've got a bunch of crazy old people that are, cooking at 106, 107 because they don't want to run the air conditioners. So we've had to pull them out, get them naked in the front yard, nose them down. So anyway, I just thought we'd share that on the anniversary of our little MCI. And we actually have like you've heard about our blood pushback where the helicopter shows up, the blood bank. We actually have a cooling pushback now. The helicopter takes off, it lands at STRAC at the warehouse. We shove a whole bunch of coolers. We actually bought a commercial ice machine with the body bags in it, and they fly out to the event and have that dropped off so that when they get to the triage area, we can start cooling them because ice is at a premium at a lot of these MCIs. And of course, we still have people getting smuggled in trains, tractors, you name it. So this problem didn't go away with all the border controls. In fact, it's getting worse.
Yeah. All right. Well, it is in this whole heat wave thing. It's just really interesting. And I'm going to start teaching people more about dew points and all that beyond the indices. Which is, it's just fascinating, just to see all this. One of the things that I've been putting out to you, just as an FYI, because I don't know if you're doing any media stuff on this, but I've been saying, I've got my usual 3 points about, if you have to go out, make sure the lightweight, light color, letter, the 3 L's and all that, and down water, avoid alcohol. But one of the things I've actually been telling people, if they're going to go out, to use a buddy system, because your first thing might be either to get faint or you get disoriented if it's real serious. And that to have somebody else along with you is a good way to do it because you can look out for each other and all that. But as best I can, I was trying to go out. I'm avoiding going out there as much as I could. And I did some yard work, and that lasted about 5 minutes.
Yeah, exactly. And also, we're having a huge problem with our populations. So people that take Flomax, which is an alpha blocker. They've got orthostatic hypotension, the beta blockers. We actually tell people, I was on call last weekend. I had about 4 or 5 of these older folks drop out, and they're still taking their Lasix even though they're dry, right? Weigh yourself in the morning. If you're not 4 pounds up, skip your Lasix, that kind of stuff. But it's a big lift. The other thing we tell people is turn up the thermostat on your house so you acclimate a little bit. Yeah. I mean, if you're sitting in a house at 62 and you go outside and it's 104, you're not going to do very well.
Yeah.
So doing acclimation is important as well.
Well, it's been an interesting few months here altogether with floods in Fort Lauderdale, which we never get without hurricane and all that. And the heat never gets. It's been interesting. So, and now malaria. By the way, I want to go back to Eileen. You had brought up something about, is there cases in Texas as well? Remember, I noticed that I made that bad joke, but have there been cases there? Why'd you put Texas down there?
There's a case in Texas right now. Mm-hmm.
Okay, got it.
But they don't say where.
They don't. But it's endemically acquired.
Got it. Okay. Good to
know. And David, you should definitely look up where. By the way, the state of Texas has a beautiful map of all its mosquitoes and where you find the different mosquitoes.
Yeah.
I'll put it on the link. See if I can find it.
So the one that brings us the Vivax is usually mosquitoes that are usually evening and early morning feeders, but the ones that bring West Nile, et cetera, could be going on all day. So just in general, malaria's just good for us to know about in terms of diagnostics now. But in general, in terms of prevention, there's so many more things that we can get, and every once in a while you get some of those other nasty ones that kind of show up that cause encephalitis and so on. So like I said, I blame NOAA for taking the 2 male and female mosquitoes on that the ark, that's where it all went wrong. So for many of us. All right. And then
there's the link for the mosquitoes of Texas, and it's brilliant. You click on any mosquito and it'll show you exactly where you find that mosquito in Texas.
Sounds like a Texas A&M trick. So that's good. They like to do that stuff. So that sounds good.
It is exactly Texas A&M.
Okay, good. All right, let me go see if Chris, do you have anything to report out of San Diego? I'm going to quickly just start. We have like 1 or 2 minutes left. So anything to report out of San Diego? We're just glad you're on with us today.
Nope. I'm going to start up our ECPR protocol end of the week. See how it goes.
Okay, good. That's it. Did we do an okay job of presenting it with Steve Sanko the other day? Did you feel Joel did okay? Anything else to add to that?
Joel and Steve were awesome.
Okay, good. All right. Just didn't know if you had any critique or anything else to add to that. That's all. Let's see. And Corey, anything else new out of Vanderbilt, Nashville?
The only thing I wanted to say was based on many of the Eagles talking about CME for our paramedics and EMTs, we are now getting an ambulance that's going to serve as a mobile learning lab and go station to station. Rather than trying to bring them to us, we're going to go to them.
Yeah, that's not a bad idea. I like it. That sounds cool.
Shame is a wonderful thing.
Okay, good to know. All righty, Dave, we kind of talked to Joe Salgan. Anything new we should know about out at North Carolina? It sounds like you're welcoming a bunch of Eagles there this week, right?
Yeah, and our
not Eagles, a bunch of NAMSP people, board members. Yeah,
air quality is 51. So come on down.
Say that again.
Our air quality is 51.
Okay, good. All right, good to know that. That's fantastic then. All righty, let's see. And then Keith, I think we had to talk it up, but you and I will maybe talk. We can even stay on this, or we'll switch over to another one after this. Peter, anything to report out of Florida as the NMSP person or from your local areas in South Florida?
No, nothing new. We had a great webinar at 3 o'clock by Mark Peel. I'll post that it's posted on YouTube on our Florida NAMSP channel.
Yeah.
Nothing more to report.
Okay, cool. Let's see. It's a Keith, Ryan, Steve Brown, Stein. Okay, got it. Hey, Ted Lee, just wanted you and I probably need to catch up just because I get receiving some invitations. I want to learn a little bit more about what my duties would be if I was serving with you on whatever committee it was. Okay, so and actually, I'd like to see if we can plan out how we can integrate the Eagles into your show next year. What the dates are for that and where it's going to be? Ted, are you still there? Ted Lee? If not, then that's it. Hey, Roger, anything from you before I sign off, or Terry? Let's go to Roger first. I got to shut this down now. We're already past the time.
Yeah, no. We're heavily interested in portable ventilators to enhance our post-ROSC bundle of care. And we're also going to try to implement Maryland's optional protocol for IV nitro for decompensated heart failure, as well as pumps, IV pumps. We're pretty big, so it's going to be a new thing. So those are the 3 things.
Okay, cool. All right. Anybody else have anything? Did I miss anybody here that like to pipe in? If not, then thank you.
Sorry, Paul.
Yeah. Yes, sir.
Go ahead, Terry.
I think
my thoughts and prayers are with the Texas Eagles, because I asked at our meeting whether the grid was going to hold up, and they were all confident about that. And then I heard last night that no generating capacity has been added since the winter storm disaster. So good luck, guys.
Okay, well, thank you. We
Actually, the funny thing is, despite what our red people think, is that windmills and solar has become a huge deal in Texas. And the issue in the winter was the gas-fired peak generators couldn't start up because all their receptor or their thermistors were frozen.
Yeah.
But we
Yeah,
haven't had any
I hear
problems
that.
with power this summer.
Yeah. So far, so we'll see. So far, so
So
good.
far.
Go
Paul,
ahead.
just one comment.
Yes, Peter.
I have all of the talks from the Eagles, and I wanted to see what is the best way to figure
Yeah.
out
Okay,
if people will
here's
be
what
okay
we'll do.
with.
Stein and I had a speakers list, right, Stein? What we could do is get you, that'll help you, like, we'll get you that listserv for that speaker list, okay? And there were some other speakers too that if you go, I'll send you the program, or if you have a program, look through it and see if we're missing anybody, okay? And then send out thing, can we use your slideshow at, put it on the website. So Stein, what we're talking about here is that we were thinking about posting we have all the talks put together, and we want to post them on our website, which I think is not a problem. Then people can even say, I don't want mine out there, take it off or whatever. But and did you talk to the Prodigy folks? Any problem with them? Because this is
I haven't had a chance to reach out yet, but I will.
I'm not so sure I'm concerned about them, because I mean they're doing a video of actual presentations that people can get. I think that's a little different than putting your slideshow out there. And so I think that it will be okay to do that, but I just want to make sure that the people who presented and whose slideshows are, if you could go through the list that Stein will send you, if there's any others that are not on that email list, if you don't mind, do that. And then I would send it out to everybody and say, we're going to put this on the website. Do you have any problem with it? That's how I would handle it. Okay.
Okay. All right. Well, we'll do that through Jim then.
Yeah, I guess Jim may not be available. Like I said, Stein has all of that list, probably the better list of speakers, possibly. And then there's a couple others to tag on, or I mean, you can look and see on your, whatever slideshows you have, you can see who gave those talks. Obviously, you could see, who they are and see if they get that. So I think I just quickly get their permission. That's all. Okay. Not a big thing. Don't make a big deal out of it.
Peter and I can get together to make that work.
Yeah, I just sent you the links, Stein, so you have them too, and we can if you want to connect at some point.
And so
tomorrow,
Stein's
would be
gonna
great.
have to know about it anyways, because he's gonna have to make sure it goes on the thing. But the main thing is I was saying was I wanted to make sure that we had everybody's permission. We're gonna put it out there. I think they all will give it. I don't know of anybody who won't want it out there. So I think
So Peter, I had Ken Shep, so I was the slide wrangler for a couple of those. And Ken's has it says redacted. His has to be redacted. So make sure that that patient's face is not on his slides.
Okay, got it.
So that's
on the
that's
OUD
part-
ones.
And Peter, that was my part of my hesitancy for just something like that showing up. Okay, so.
Okay, all righty. Sounds good. Thanks, everyone.
So I won't repeat what you said, what your job was, but David, but that was funny as hell, right? So it's good.
Yes, I was the slide bitch. You got it.
Okay, good. I'm glad you said it, then not me. All right. Well, listen, I'm going to get off the call. I have to catch up with Keith, and I'll see you guys later. Then thank you very much. Welcome back, my friends, to the show that never ends, but it will be 2 weeks from today. We're going to actually skip over, 1 day for the first time in I don't know how many years it's going to be. So
May the fourth be with you.
yeah, may the fourth be with you. That sounds right. And then then there will be the revenge of the sixth if you have too much fun on the fourth, right? All right, I'll see you later. Take
All
care.
right, see you guys. Bye.
Bye.
Hello, and thank you for calling Lillard Wise Shagenda. If you know your party's extension number, you may dial it at any time. Or for our company directory, please press 9. If you would like to leave a message in our general delivery mailbox, please press 1. Again, thank you for calling Lillard.
You are being transferred to the operator.